Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. I wanted to mention that I do get emails from time to time and specific requests to cover basically certain drugs. And sometimes a lot of the requests, I've already covered that medication. So if you're looking for a specific drug, a specific class, I've covered a lot of them already in the I believe I'm on year 4 now. So go to reallifepharmacology.com, hit the podcast button, and there is a search tab. So if you're looking for bupropion or SSRIs or whatever drug you want to try to potentially study, go take a look at that, because I've definitely covered a lot of drugs already, and many of them might have been covered already. And it's a good way to easily find them and search them. Is just to go to reallifepharmacology.com, hit the podcast tab, and then find the search tab, and you should be able to track that down. With that said, as always, go to reallifepharmacology.com also to get your free 31-page PDF on the top 200 drugs. Great study guide, great review, whether you're taking pharmacology classes or board exams or out in practice and just need a little refresher. So go do both of those things at reallifepharmacology.com. All right, the drug of the day today is Clonazepam. Brand name of this medication is Klonopin. Mechanistically, how does this drug work and what does it do? So from a mechanism of action standpoint, it enhances the action of GABA. And if you remember from physiology, GABA is an inhibitory type neurotransmitter in the central nervous system. So think of that as basically slowing you down, causing sedation, that type of thing. And that should give you a sense of what the medication can be used for. So anxiety, I've seen it used for insomnia, agitated states certainly, and also seizure prevention. Now, I will say with Clonazepam specifically, it's really only given orally. So for an acute seizure, we're not going to use Clonazepam. We're typically going to use an injectable benzodiazepine such as lorazepam, for example, there. Or potentially there is rectal diazepam as well. But again, you're not going to use Clonazepam because it only comes orally for an acute seizure. That would not be appropriate. Dosage forms, as I mentioned, there's oral and there's also oral disintegrating tablets. Most common dosages I've seen 0.25 up to 2 milligrams. In geriatric patients, this medication is on the Beers list, so it's potentially inappropriate to use in elderly patients. So if we're going to use it, we're definitely going to want to start low and go slow in most situations. So you may even see starting doses down around 0.125 milligrams, maybe 0.25 milligrams. But again, we're going to use it a lot more cautiously with the dose in our geriatric patients because they're definitely more prone to some of the adverse drug reactions. Getting into those adverse drug reactions, understanding the mechanism, basically potentiating the effects of GABA, which again is kind of that inhibitory neurotransmitter, sedation, slowing down that CNS activity. So sedation, cognitive slowing, confusion, slurred speech can happen. Certainly it's going to increase the risk for falls and ataxia, maybe a little bit of shuffling if patients are moving slower that way. Rare cases, I have seen it cause almost a disinhibition. And in a lot of ways, clonazepam and other benzodiazepines have similar effects to alcohol in many capacities there. So that's a good way to remember it. I mean, it's not a total overlapping mechanism there, but if you think of alcohol toxicity, you'll definitely see a lot of similarities with benzodiazepine toxicity in the sedation, fall risk, cognitive impairment, slurred speech. A lot of those go with both alcohol and benzodiazepines. All right, addiction and dependence. I would definitely want to mention that as well. It is a controlled substance, so we certainly run that risk as well with clonazepam. From a pharmacokinetic standpoint, clonazepam is an intermediate acting benzodiazepine, so it's kind of got a middle of the road half-life compared to other agents. Lorazepam, probably one of the most commonly used benzodiazepines, that's got a little bit shorter half-life than clonazepam. Diazepam, especially in geriatric patients, can have a really, really long half-life. So that's generally considered a longer acting benzodiazepine. Clonazepam is kind of in the middle of the road a little bit there. CYP3A4. I'm going to cover this a little bit, obviously how it will affect drug interactions, but CYP3A4 is an important enzyme in breaking down and ultimately shutting off the activity of clonazepam. So that'll be important, certainly. Urinary elimination. Generally, we don't have to worry about it too much with clonazepam. It is primarily deactivated by metabolic processes. So with that said, renal dosing, we typically don't have to worry about that too much. One last kinetic property I did want to mention was onset of action. Usually in the range less than an hour for the onset of action, maybe 30 minutes as far as the ballpark of when that drug's going to start working. Obviously, like I mentioned before, giving that as an oral medication to somebody who's having an active seizure, not appropriate. You can't really give it to somebody who's potentially not conscious and that type of thing. And the other aspect of it is when you take a medication orally, typically it doesn't work that quickly. It doesn't work within a couple of minutes. It takes a while to basically get absorbed through the GI tract. So really two big strikes against using that for very, very acute situations, particularly in the case of seizures there. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for Pharmacist Board certification study material like NAPLEX, BCPS, ambulatory care, geriatrics, and many others, go check out meded101.com/store, S-T-O-R-E. We've helped thousands of pharmacists and pharmacy students pass their board exams, and we can help you too as well. So go check that out, meded101.com/store, S-T-O-R-E. In addition, if you're a nurse practitioner, nurse, med student looking for more resources on pharmacology and case studies and drug interactions, tons of different books and other resources at meded101.com/store, S-T-O-R-E. So go check those out. Any purchases there go to directly support this podcast. All right, drug interactions. So first and foremost, with clonazepam, I want to start with CYP3A4. So understanding that CYP3A4 is a primary enzyme that helps break down this drug and essentially deactivate it. If we have enzyme inducers or enzyme inhibitors, that could cause changes in the concentration of the drug. So CYP3A4 inducers, phenytoin, rifampin, carbamazepine, St. John's wort, all these drugs can potentially lower concentrations of clonazepam and essentially lower the activity of clonazepam. Now, inhibitors of CYP3A4, they're blocking that enzyme from working. They're going to cause just the opposite. They're going to cause concentrations of clonazepam to go up. So classic examples I think about there, grapefruit juice. Some of the azole antifungals are definitely strong CYP3A4 inhibitors. Diltiazem, verapamil. So there's lots of medications that can inhibit CYP3A4, and it's important to pay attention to that. So let's take a quick classic case example. Say verapamil is started in a patient taking clonazepam. What you would potentially expect, as long as that clonazepam dose stayed the same, would be increased concentration. So you're more likely to run into sedation, slurred speech, confusion, fall risk, all that stuff associated with higher concentrations, and of course the adverse drug reaction profile there. Other drug interactions that need to be mentioned, CNS depressant activity. Okay, going back to the mechanism of action, how this drug works, it's going to cause CNS depression. Now, when we add other drugs such as diphenhydramine, hydroxyzine, so those are the H1 antagonists, trazodone, antipsychotics like Seroquel particularly, any drug that's sedating is going to have additive effects there. And there's actually a boxed warning with a specific class of drugs, and that would be the opioids. Using benzodiazepines like clonazepam with opioids can increase the risk for overdose, particularly respiratory depression and ultimately death. So that is a huge boxed warning. It's definitely something I've seen come up on board exams and pharmacology exams all the time. When you use a benzo like clonazepam with an opioid like morphine, oxycodone, fentanyl, you name it, there is a significant increased risk of respiratory depression and essentially overdose symptoms from the opioid in combo with the benzodiazepine. All right, well, I think that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls. If you enjoyed this episode, found it helpful, please do me a huge favor. Leave a rating, review on iTunes or wherever you're listening. Share us with friends, colleagues, students you may be precepting, anyone healthcare oriented who may benefit from a little pharmacology education. So please share this podcast with them. If you want to track me down, suggestions, comments, emails, mededucation101@gmail.com. I do try to reply to everybody I can. I get quite a few emails, but that's great. It definitely helps me realize that I'm trying to help a lot of people, and that's a great thing. So again, mededucation101@gmail.com. You can track me down on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. Nursing students, go check out MedEd 101 Guide to Nursing Pharmacology. If you're geriatric related, if that's your field of study, whether you're a physician or a nurse or a pharmacist, Perils of Polypharmacy is one of my newer books. Lots of case studies, clinical pearls in there to help you eliminate polypharmacy. So all those links you can find meded101.com/store. Thanks so much for listening. I hope you guys have a great rest of your day.